All right. I just want to take a moment and welcome everyone to the Essential Substance Abuse Skills webinar series. My name is Ella Driscoll, and today Avis Garcia will be presenting clinical evaluation assessment. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network out of Iowa City, Iowa. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, a handout of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. We are currently waiving any fees for CEUs during quarantine, and when we send out our follow-up email, you can simply reply to the email that we send out to get your certificate. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with this event. This feedback is critical to our future work, and we greatly value your opinion and would greatly appreciate your time in sharing your thoughts with us. This project is supported by the Substance Abuse and Mental Health Services Administration, SAMHSA. This content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. Before we get started today, I also wanted to acknowledge right now that we're in a current tense political climate, and we know it's very, very stressful for so many people, and we have those on the call today with differing opinions, but we just want to remind everyone that, as always, we want to be respectful of each other. We've also, in the past, hosted a wellness series that might be helpful for some, and so I will post that in the chat box as well. So today, our speaker for this event is Dr. Avis Garcia. She is an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. She earned a doctorate in counselor education and supervision at the University of Wyoming, and she is also a licensed professional counselor and licensed addiction therapist. For 19 years, she has been a mental health provider in the treatment of Native American youth and families. And here I would like to hand it off to you, Dr. Garcia. Welcome so much, and thank you so much for being here.
Thank you. You can go on ahead and go to the next slide. Okay, today's goals of this presentation, as you can see here, is to define the assessment process, identify some assessment instruments, define DSM-5 criteria for substance abuse and dependence, specifiers, and multi-axial assessment, and to describe the ASAM levels of care and diagnostic and dimensional criteria. What is an assessment? The purpose of screening is to determine whether an individual needs an assessment. The purpose of assessment is to gather detailed information needed to develop a treatment plan that meets the individual's needs. So we can go to the next slide. And this is a sequential assessment, which generally starts out with screening. Screening is a process of evaluating the possible presence of a particular problem. This outcome is normally gathered by a simple yes or no. An assessment is the process of defining that issue, determining a diagnosis, and developing specific recommendations and an individualized treatment plan to address the issue and our diagnosis. You can go to the next slide. From screening to assessment, the amount of information and time needed accumulates over time. So as you can see at the very bottom of this upside down pyramid, the screening takes less time and less money. A lot of medical professionals are now trained to ask brief screening questions and oftentimes refer people to get a substance abuse assessment. Maybe they're presenting with some medical issues that are related to drug or alcohol use. And it moves from the screening to doing the personal assessment, and the amount of information that is collected also is greater. So it goes from very brief to taking a longer time. So it's also looking at the problems the individual has, as well as giving them a personal assessment so that they can take a look at themselves as well. You can go to the next slide. A multi-dimensional assessment. An initial step is to ensure that the patient meets a level of care by gathering the patient's medical history, such as previous treatment, current therapy, or prior use, including medical, behavioral, social, and financial. And its use is what are they, and this is where we look at their substance use. We want to know what they're using, how long they've been using it, when did they start using it, how often, when did they first start using, and when did they last use. Signs and symptoms we'll be looking for include blackouts, meeting social and family work obligations, consequences such as arguments, employment problems, cultural loss, spiritual loss, and educational loss. This establishes the severity of an individual problem: mild, moderate, intermediate, or severe, and it determines the appropriate level of care and guides the treatment planning, relapse potential, or continued potential. You can go to the next slide. The content of screening is a brief process that just answers a few questions and also looks at whether the alcohol or drug problem might be present. If so, whether it is likely to require a brief intervention or a specialized treatment. Okay, here's a polling question, and did we get to set these up for people to respond, or they just want to respond in the comment section? This is a polling question that is answered by true or false. The statement is: collateral information when assessing a patient's needs is rarely required to determine an accurate diagnosis. What do you think, true or false? Okay, you're correct. It is false. Collateral information is vital to help to determine a diagnosis and the course of treatment. And a lot of the assessments that are referred to my agency where I presently work are sent to us by the criminal justice system. And a lot of them are on probation or parole, and a lot of times I don't get the information I need up front. So we usually request that we get their background information so that we're able to use that before we start the interview, so that I'm able to use it throughout the interview process as well. A lot of times they aren't honest, and I'm not a lie detector. So oftentimes I've believed a client, and it still happens to me now. They'll tell me their story and I believe it, and then the probation officer contacts me and says, oh no, did they tell you they were using? And they've been drinking and they've got positive drug tests. So it's very important to get that information. I used to have a questionnaire that I would have them give to a friend or a family member to give me some information from someone else's perspective. And because of all of this HIPAA violation stuff, I've stopped using that questionnaire, but sometimes I will share it with a client and ask them, what would your family think, or what has your family said about your use? So it's good to get all sources of information if possible. Okay, go to the next slide. Okay, the content of problem assessment. Retrospective is the past, what led to what's happening now. Prospective is the future, possible outcomes. We will also look at lab results, UAs, breathalyzers. We have mouth swabs, all determined by time and specific factors. So a lot of our testing, we can often tell how long when they last used, how recent the use was, because the drug tests are able to, I think the tests that we use can detect alcohol up to 48 hours. So we send a lot of our UAs off to a lab in California that does a split, they call it a split level testing, which means they'll run the test not once, but twice to verify that they're presenting accurate levels of substance that might be available in someone's system. I'll pass that to the next slide. Content of problem assessment. We're looking at the signs and symptoms of alcohol or drug use disorder. And cross-referencing all self-reports with collateral reports, arrest records, lab results can often give a more accurate clinical picture of the patient's overall alcohol or drug use history. There are 11 criteria that are used to determine a substance use disorder severity. Another common diagnosis for substance use disorders is unspecified XX, e.g., it could be alcohol-related substance use disorder. I've been getting some people who use spice, and so that is like a synthetic form of marijuana that's not marijuana. So that would be an example of a unspecified related, because we don't really have that classified as a category of a substance. And self-report questionnaires can be used. It just depends on what the agency uses and a lot of times what the state's requiring to complete an assessment. Next slide. You have to remember that the amounts do matter. One drink is not a large bottle or man can of beer, or a glass of liquor. So we need to look at all the different kinds of alcohol, because for them, they might say, oh, I have a couple of beers, and we might be thinking about this can right here, and maybe they're 40-ounce cans or 40-ounce bottles. And some people might say they're having a glass of beer, when I've seen some of the restaurants might have really big glasses of beer, and some big guys will drink a whole pitcher, and for them, that's one beer. And a glass of wine is 5 ounces of table wine. And as you look at this, the level of alcohol concentration goes higher with the lesser amount of alcohol. So then we have the 80 proof spirits, the whiskey, gin, rum, vodka, tequila, and a lot of the substances that they use. If some people drink mixed drinks, they don't stop to realize that some of those mixed drinks might have several shots of this 80 proof spirits in it. I think the Long Island iced tea, I was told by one bartender one time that they put like 7 shots of different liquors in that. So some people might not realize that they've drinking like plenty of alcohol without even realizing it. You can go to the next slide. The content of problem assessment. What we are doing is looking at the consequences of alcohol and or drug use. These are some screening assessments. There is the Michigan Alcohol Screening Test, the MAST, Drug Abuse Screening Test, DAST, now called the Drug Use Questionnaire, an Alcohol Use Inventory, and an alcohol use identification test, use disorder identification test. And the one that I'm much more familiar with is the addiction severity index that is at the bottom there. You go to the next slide. The content of a personal assessment examines problems to determine if they are attributable to the use, such as medical status, psychiatric status, vocational issues, personal problems, sexual problems, social support, family structure, and need for recovery support. So there's a lot of different areas that we look at when we assess someone. We don't just look at drug and alcohol use. We like to see how is this affecting their life, their health, their mental capacity. Go to the next slide. Content of personal assessment. When they come from a different population or different communities, so we need to be aware of that. The use of leisure time, family history. Do they come from a family history where there's generations of alcohol use? Have they had any other treatment before? What their level of intelligence is, and oftentimes it's not obvious right up front. And I don't mean to say that someone is like, they're not intelligent, but I've had some people come in that don't know how to read. And I've always appreciated when they're upfront and saying, you know, my wife or girlfriend is here because she has to do stuff for me because I can't read. So sometimes we have to be aware that a lot of these people might have special needs that we need to find a way to work with them and meet them where they're at. So the cognitive functions also includes the reasoning, memory, attention, the language that they're using, and what leads directly to the attainment of information, thus knowledge. Their personality, treatment goals, social stability, situational factors, and spirituality. So it's a pretty comprehensive assessment that is done. You can go to the next slide. The overview of the assessment process includes a 6-step process consisting of detection, classification, functional assessment, functional analysis, treatment planning, and recovery capital. We would be looking at some of the reasons the individual is behaving in a certain way, looking at their resources, which are necessary to begin and maintain recovery. And what recovery capital is, the depth and breadth of internal and external resources that can be used by someone to begin and sustain wellness from addiction. So, you know, is their family supportive? Are they living in a safe environment? Are they attending any self-help meetings anywhere? What are they doing for themselves to help themselves start the recovery process on their own? Go to the next slide. Drug testing. I do know one agency on the reservation where I'm from does do drug testing up front. And we often, well, we would tell them that we're not going to turn you into anybody or report you to anyone. We just want to get a baseline to know where you're at so that if you need treatment, we're able to monitor use. And in my program here where I work now, we've discussed doing drug testing, which we haven't done, but when they enter our treatment programming, we do random drug testing on all of our clients that come to outpatient treatment services. So it just depends on the agency and what their policies and procedures are for completing a substance abuse assessment and whether or not they want to do drug testing. You can go to the next slide. This is another polling question. What is the most common form of drug screening test performed in most substance abuse treatment centers in the United States? Okay, you guys are all right. That is the most common. My husband is a truck driver, and he has to get UAs randomly all the time. And he said this last time they took a part of his hair. And so I thought, oh, that's pretty interesting. But yeah, the UA is pretty common. You can go to the next slide. Detection. We are looking for observable issues that indicate active use. Are they shaking? Are they having difficulty concentrating? Looking at this, if a patient is coming off of alcohol, they may be very alert. While substances such as meth, they may be very tired. Can you smell any substances? And sometimes I can smell right before I even take them into my office. So we do have a breathalyzer, and I highly suggest that you turn them away if they're under the influence and ask them to come back at another time when they're free of substances and not currently under the influence. And when I worked for corrections, oftentimes it was hard for me because I would encounter parents of children, and their children might be in the car, and I could tell they were under the influence of something, and they would admit to me, but I always tell them, I'm not here to get you in trouble or anything. We're here to help. So sometimes that's a good way to intervene with the family. So we're looking to look at potential problems, past and current use of alcohol, tobacco, or other substances, lab tests to screen for use, and any negative consequences that they might have. And like I said, most of these people don't come on their own and say, I think I have a problem. 9 times out of 10, the criminal justice system is what brings them for the substance abuse evaluation. Go to the next slide. Classification to assess possible DSM diagnoses, which can be used to rule out a substance use disorder. And we're often focused on the previous 12 months of when they came into the office. And usually the last 30 days, the ASI looks at the last 30 days and in the last year. So it looks current, and then it looks at long-term use. Again, collateral information is key to make an informed, accurate, objective classification. So like I said, the Department of Corrections provides information most of the time when we try to get that information up front. So it lets us know if they have a history of using and they've been diagnosed before. So they're usually pretty good at getting really good information on the person that's being assessed. Next slide. A functional assessment. Strengths can be of use to get patients to remain on track. Culture is also a form of strength and a prevention tool as well. So we want to get patient information, use all available collateral sources, assess the patient's range of different needs, identify the patient's strengths, identify their support system, and look at their recovery capital. We can go to the next slide, which is the functional analysis. We want to look at family, friends, home environment. What do they do for their leisure time, such as watching games with friends who use, maybe they're on a pool league or a bowling league, and the game itself may become attributed to use. Depression. Alcohol is a depressant, so it can actually make matters worse. Maybe they had a recent breakup, divorce, loss of a loved one, and using substance as a reliance upon, as a crutch and a coping tool, which can lead to consequences down the road. So we need to take a look at the person's, how they're doing. And a lot of times what I see is they all have a reason why they started using or why they relapsed. And it's all of the possible reasons that I just shared. So it's good to look at that when you're considering what they might need help with in addition to. Could go to the next slide. Methods of obtaining information. Face-to-face allows for the use of micro-counseling skills. We're looking at body language, posture, crossing arms, sitting straight up, gestures are expressive. A lot of people like to use their hands when they're talking, and facial expression and eye movement. You're gathering comprehensive information, so you got to try to stay objective and stay on task during the assessment process. A lot of times I run into people that are storytellers like myself, so I might ask a question and they might have a story, and I'm like, we're doing an assessment here. I'd like to hear that later. Let's keep going. So some of these assessments are paper and pencil tests. Some parts of the assessment materials we do hand to the client and let them fill that out. Some are semi-structured interviews and some are structured interviews. The addiction severity index is pretty structured, but to really get an accurate diagnosis, I like to add a few other things to it. There are some computerized assessments. I'm not too fond of the self-testing. I worked in an agency before and they're still doing it where they have the ASI on a computer. They actually have a room of computers and they just put the client on the computer and they get to do the ASI, answer everything themselves. And I saw that a lot of these people really minimize or lie. They don't give. I would prefer a face-to-face interview so that you can ask those questions. I think that's a better way of doing an assessment. On to the next slide. Now we're going to look at assessment tools. And next slide. You can switch it. Okay. This is the tool that the state of Wyoming requires all substance abuse treatment agencies to complete on every individual that is presenting for a substance abuse evaluation. They will not accept any other tool. This is like the state mandated requirement. You do the addiction severity index. And this was developed in the 80s and it's used internationally. So that means it's a worldwide tool. So that has a lot to say about the use of it. The ASI is used in the AccuCare system with the Indian Health Services, and it's a semi-structured interview, and as you see here, it looks at 6 important areas. It looks at their medical status. Are they having medical problems from use? Employment and support. Are they working? When's the last time they worked? What's the longest job they've ever held? And alcohol use, drug use, legal status. There's a whole long checklist of where you ask them of several crimes. Have they been charged with any of those? And then there's a little check mark. Was it drug and alcohol related? So not only are you looking, you're checking to see if their use is related to that. So are they there because they're selling drugs? Are they in possession? Family and social status. This looks again at family history, looks at mom's side and dad's side. Does any of your family have any problems with drug, alcohol, psychological? Is this a family generational thing? Looks at their, how they're getting along with people. So a lot of times I get a lot of people that just don't want to respond to this area. So not that I always skip over it, but I just noticed a lot of people are really reluctant to answering that one. And then psychiatric status. At the very end, there are several questions that looks at depression, anxiety, memory, anger control. Are they having any hallucinations? So it's things like that. We can go on to the next slide. Another assessment is the comprehensive drinking profile. Again, these are just some extra ones to, if you're looking at other tools besides the ASI. This is a structured interview, looks at the history and current status of drinking problems and related matters and consumption and problematic behaviors. You can go on to the next slide. There is a timeline follow back. Using a calendar or common holidays or seasons can also be an effective means to establish an accurate timeline, so we can get a better look of how long they've been drinking, how often they drink, how much, under what circumstances. Again, looking at where are the triggers, the connections between use and significant events. A lot of people will say, oh, I only drink like during special occasions or socially. And so it's like, well, how often do you go out to be social? So a lot of times I feel that they minimize. So I've often shared with my years of experience of when they do report that you might want to double or triple the amount that they disclose. Go on to the next slide. Here's another one. It's called the Inventory of Drinking Situations. It looks at 8 categories: emotional, urges and temptation, negative physical states, interpersonal conflict, positive emotional states, social pressure, and testing personal control, and positive social situations. You go to the next slide. This is the Situational Confidence Questionnaire. It's a self-report instrument that you can give to the client and they will fill it out themselves. And they would rate themselves from 0 to 100, with 0 being they're not confident and 100 that they're very confident. How likely they will be able to resist the urge to use heavily under certain situations. You can go to the next slide. The Substance Abuse Subtle Screening Inventory is a 1-page self-report screening. It looks at the resistance to faking. The way they answer these questions can actually reveal whether they're being open and honest with you. And some of the questions are asked more than once. They're just asked in different ways. And it's a quick pencil and paper assessment that a lot of places use. And there are places in the AccuCare, the Indian Health Services uses to enter the scores from that. And there's a little template that you drop over it and it lets you get the scores that you need. You could go to the next slide. Okay, and then there's the GAIN. It's the Global Appraisal of Individual Needs. This is a very lengthy assessment that it's not one that I use. Some places use it, and the 8 sections it looks at, you can see here: background, substance, physical, risky behavior, mental health, a lot of the same things that the ASI covers, but it's just more detailed, a lot more questions and a lot more time. And when you're working in an agency, time is money. Go to the next slide. Now we're going to look at the DSM-5, the substance use related disorders. This is the Diagnostic Statistical Manual, the big fat purple book that we use to look at the criteria to diagnose substance use and mental health and personality disorders. And it's a major tool that we use regularly in our work. You can go to the next slide. The substance-related disorders in the DSM-5 chapter on substance-related and addictive disorders includes 10 substance-related disorders. There's alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, stimulants, tobacco, and other substance-related disorders. Go to the next slide. How many diagnostic criteria are listed in the DSM-5 in the section for substance use disorders? You want to take a guess at that one? Okay. 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 I'm watching the comment section. Okay. The answer is B. There are 11 diagnostic criteria. And so when you write up your assessment, when you give them the diagnosis, we have to back up that diagnosis. So if it's for alcohol and we're saying we're diagnosing them with the alcohol use disorder, we could say as evidenced by the following. And so then we just list the criteria. You can go to the next slide. Substance use disorders. Almost all substance-related disorders in the DSM-5 include use disorders, intoxication, and withdrawal. Almost all specify that the substance use disorder can be mild, moderate, or severe. With the exceptions of caffeine use, there's no severity rating, hallucinogen disorder, there's no intoxication or withdrawal criteria. Inhalant use disorder, there's no intoxication, and tobacco use disorder, no intoxication. You can go to the next slide. Alcohol use disorders include alcohol use disorders that are mild, moderate, and severe. Alcohol intoxication, alcohol withdrawal, and unspecified alcohol-related disorder. And in the little cloud there, the distinction between alcohol abuse and dependence has been eliminated in DSM-5. So in the old gray manual that we used to use to diagnose people, they changed the whole criteria and how we look at that. We no longer say they're abusing alcohol or they're alcohol dependent. We diagnose them with an alcohol-related disorder that is either mild, moderate, or severe. Go to the next slide. We have another polling question. If a patient has a diagnosis of alcohol use disorder that is moderate, how many DSM criteria would they need to meet? Okay, you guys are doing pretty good. The answer to this is D. They would have to have between 4 to 5 criteria to diagnose them as having a moderate disorder. You can go to the next slide. Alcohol use disorders. This is how they are, the criteria that we use to rate the severity or the intensity of their use problem. A mild alcohol use disorder reflects the presence of 2 to 3 symptoms. A moderate alcohol use disorder reflects 4 to 5 symptoms that are present. And a severe alcohol use disorder reflects 6 or more symptoms. So all 11 of the DSM-5 symptoms are used to determine what criteria they meet. We can go to the next slide. Alcohol use disorder, it's a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of 11 listed symptoms occurring in a 12-month period. Go to the next slide. Symptoms of alcohol use disorder. This is the DSM criteria, all the 11. This is the first 3. So the first one is using larger amounts over a longer period of time. A persistent desire or unsuccessful efforts to cut down or control their own use. spending a great deal of time in activities necessary to obtain, use, or recover from its effects. The next slide. Symptoms of alcohol use disorder. This is 4 and 5. Do they have cravings, or is there a strong desire or urge to use alcohol or whatever substance it is that they're presenting with? 5, is the recurrent use resulting in failure to fulfill major role obligations, such as they're about to lose their job, lost their job, don't have a job, maybe they're not doing well in school and things aren't going so well at home. We can go on to the next slide. Here's 6, 7, and 8 of the 11. Tolerance is defined by either of the following. A need for markedly increased amounts of alcohol to achieve intoxication or the desired effect. B, markedly diminished effect with continued use of the same amount of alcohol. So that means they might have started drinking and they only needed 2 drinks, and now they need 6 or 7, or they progress to drinking distilled spirits because beer just doesn't cut it anymore. 7 is looking at their important social, occupational, and recreational activities that are given up because of use. This one says, I used to dance and visit my friends and family, but since I started drinking, I don't go, I don't do that anymore because it all involves that. Recurrent alcohol use in situations where it's physically hazardous. DUIs is a real common one that I see almost daily where I work. And actually, we were in the news not too long ago in Cheyenne, Wyoming, that we had like the highest DUIs in this town, in this state. So I was pretty surprised by that because they didn't mention anything about the reservation. So we can go to the next slide. Symptoms of alcohol use disorder. Remember, withdrawal from alcohol or benzodiazepines can be life-threatening and may require medical stabilization. Benzos, tapers are also commonly used to manage acute alcohol withdrawal. So sometimes they use another substance to help them with the severe withdrawal. And so I used to think if you just took the alcohol away and kept it away, then they can't drink, but that can be really dangerous. So if you're trying to help someone and they say they just need a drink, sometimes you need to just get them a drink to get them to where they can get help. You could go to the next slide. Symptoms of alcohol use disorder. Okay. This is the tolerance and withdrawal. I think I just covered this, so we can skip over that, sorry. Core specifiers. DSM-5 also has remission specifiers. So this means they haven't drank for a certain amount of time. Early remission means the patient doesn't meet any of the criteria for at least 3 months, but less than 12. So that would be early remission. Sustained remission, they're not meeting any diagnostic criteria for at least a year. So you could, when you diagnose them, you could specify if they're early, partial, early full, sustained full. So you just want to look, are they an early remission or sustained remission? So it's good to see how long they've been able to maintain their recovery on their own. We can go to the next slide. Now we're going to talk about recovery-oriented systems of care. And thinking about the future in our field, I see one new trend that holds particular promise, and that is the recent shift in thinking away from the clinical treatment model towards a recovery and recovery-oriented systems of care. The shift is leading us to see recovery as less of an event, but more as a process. The recovery paradigm also invites us to move from a narrow focus on the deficits that accompany addiction to the strengths that come from recovery. We focus less on pathology, more on their wellness. We focus not only on recovery from addiction and its negative effects, but also on recovery of a meaningful life in the community. So we want to look at what they're wanting to change in their life to make their life better, and not just looking at just quitting substances. Of course, that's important, but looking more at the overall wellness of how they can improve their life. We could go to the next slide. The recovery-oriented systems of care shifts from how do we get the patient into treatment to how do we support the process of recovery within the person's environment. So we like to give them the credit for all the work that they do. And we just let them know we're just here to support you. We don't actually do anything to them to make them better. We just provide them with the education that they need. The next slide is another polling question. Which of the following is not a key component of the recovery-oriented system of care approach? A, the various support systems need to work separately with the patient. B, builds on strengths and resilience of the patient. C, offers a comprehensive menu of services that can be adjusted to meet the needs of the patient, adjustable to the patient's pace and recovery process, which is not a part of the recovery-oriented system of care. The answer is A. Okay, on to the next slide. More on the recovery-oriented systems of care. Treatment agencies are considered one of the many resources for the patient. So it's not just they come just to treatment. What else are they doing in their life? No one source is more important than another. Various support systems need to work together to support the patient. Go to the next slide. As you can see here, the individual and the family is in the center. They have their wellness, their health, and their recovery programs. So these are person-centered, self-directed approaches that the person can build on their own, using their own responsibility, their strengths, what resilience they have, using their family, the community to achieve health, wellness, and recovery. So you want to get the family involved as much as possible if you can do that. I really try to refrain from, let's just send that person to the treatment and get them fixed and bring them back. The family needs to understand that they play a vital role in that person's recovery. We go to the next slide. The recovery systems of care offers a comprehensive menu of services and supports that can be combined and adjusted to meet the individual's needs and chosen pathways to recovery. So again, you can see in the middle there that they have vocational services, peer support services, maybe they have PTSD, maybe they have health issues, maybe they need help with childcare, education, housing, transportation, spirituality, legal and financial. So they have all these needs, and it's good to be resourceful in your agency that you work at. And at our office, we have a 2-page sheet of every resource that is available in this town, the city of Cheyenne, so that, if they're looking for, maybe they did get a place and they have no furniture, so we can direct them to places where they can get, possibly free or inexpensive furniture that they might need. So you can go to the next slide. Recovery-oriented systems of care are person-centered and self-directed. I work at an agency that is CARF accredited, and CARF requires us to provide person-centered services. And what person-centered means is the client leads their treatment. They tell us what they want and we do what we can. They need to feel like they have control and say in their own treatment. And really, this is your very basic counseling skills. So I always tell people if they just want a quick refresher, just look at the basic counseling skills. So you're looking at their strengths, getting the family involved, the community involved, let them take responsibility for their health. Did you make it to the doctor? Some of these people don't do that until they get to treatment, and then they realize they have to start taking better care of themselves. And offer a comprehensive menu of services that can meet their needs. My agency offers mental health services. We offer corrective thinking services. You got to be able to give them different things and be able to adjust to the patient's pace and recovery process. If you go to the next slide. Recovery-oriented systems of care encompass and coordinate the operations of multiple systems that provide responsive, outcomes-driven approaches to care. Requires an ongoing process of systems improvement that incorporates the experience of those in recovery and their family members. We often give surveys to our participants that come to our agency, and we enter that into a little program that we have that analyzes it, because we want to know that our clients are satisfied with the services that we provide. And if not, what are we going to do to make it better? Affects our involvement in the assessment process, and the patient is the equal partner. They need to feel like I said, they need to feel like they're in control. And I think that's a real important part of their recovery process. Go to the next slide. Elements of recovery-oriented systems of care. Again, person-centered by Carl Rogers. This is individualized, responsive to culture and personal belief systems. On the reservation, we offer crafts. We have a sweat lodge. We bring elders in. Maybe we connect them to the language programs. A lot of people really get away. I've seen on natives where I feel when they've been drinking or using for so long, they get away from our cultural and spiritual beliefs. And I've seen amazing things happen that once we hook them up to those cultural aspects, I've seen people just really turn around. It's been amazing. I've seen some people that don't come to group, but we have a sweat, they're there, and they really enjoy that. So I'm glad that we're looking at providing our culture as part of our treatment. Commitment to peer services. We have one peer specialist, and she checks in with everybody at least once a month. I mean, like everyone that comes, she reaches out and contacts them and checks them. They have her number at all times in case, they're in a situation and they just need someone to talk to. You want to involve the families and other allies back home. Like I said, we offer the sweat lodge. And so when we do that, we encourage them to bring their children, bring their wife, and then, we provide a meal at the end, and it's good to see them interact with their family. Again, you want to have ongoing monitoring and outreach. So always checking on their progress. You use that treatment plan as a guide. Go to the next slide. Elements of recovery-oriented systems of care. They're cost-effective, outcome-oriented, integrating services and no duplication, competency-based, use collaborators and partners, system-wide education and training, a continuum of care, a lot of research-based services, and flexible funding services as well. To the next slide. Now we're going to look at the ASAM criteria. This is the Addiction Society of Addiction Medicine. It looks at the dimensions, risk ratings, and levels of care. That is a big, that's another big purple book that we use frequently. We can go to the next slide. A polling question again. What does ASAM stand for? Well, I just gave that away. Sorry. It's the Association of American Medicine. So we can go to the next slide. ASAM criteria background, also around the 80s. The task force integrated existing admission and continued stay criteria sets. Decided to relinquish ownership and branding of the criteria. So the medical, this is what we're looking at when we determine is their treatment medically necessary. So this is what guides that. The goal of the ASAM criteria is on the next slide. To unify the addiction field around a single set of criteria. If you go to the next slide. Levels of care are 0.05 through 4. 0.5 begins with early intervention, which where I work, our DUI classes are early intervention. Pre-treatment services, early intervention services, risk assessment screenings, and then we go on to level 1 and level 2.1, which are our outpatient programs. Our level 1, we can specify however many sessions we want that person to attend. They could be provided in group or it can be provided individually. The 2.1 is more intensive. That's what we call our intensive outpatient treatment. And we provide 9 hours of treatment per week at the agency where I work at. And it's pretty much the standard in the state of Wyoming. So every state differs on their criteria for level 1 and level 2.1. And I've seen Colorado is our neighbor, and oftentimes we get clients who got a DUI in Colorado and their DUI requirements are like, I want to say 10 times more work than what we've been putting people through. Then there's a partial hospitalization, level 2.5. Residential treatment is level 3.1, 3.5, 3.3, 4, and 7. So this is people that need residential care. They need that 24-hour structure. Some of them need a psychiatrist. Some of them have medical problems. So that would be an agency that would be able to provide all of those services to that person, and detoxification. And then one that's more common now is also the opioid treatment program. Next slide. Excuse me. The ASAM criteria has 6 dimensions. Dimension 1 is the acute intoxication and or withdrawal. Usually when they come for an assessment, they haven't drank and they're doing fine. But then sometimes we have people that are withdrawing and we need to get them to the emergency room. Dimension 2 is your biomedical conditions and complications, liver problems, mental brain problems, diabetes, high blood pressure. A lot of people have medical conditions that can be caused by their substance use or made worse by using. Dimension 3 is the emotional, behavioral, and cognitive conditions and complications. Dimension 4 is their readiness to change. So if you know about the readiness to change cycle by Prochaska and DiClemente, are they contemplating, are they maintaining, thinking about it? Dimension 5, the relapse, continued use, or problem potential. Maybe their background shows they've tried and whatever they've done hasn't worked. So there's different criteria that lists the criteria in more specific wording than this, but this is just a brief overview. And dimension 6 is their recovery and living environment. Do they have a stable living situation, or where are they living? We can go to the next slide. Here we have another polling question. Which ASAM dimension is associated with determining a patient's willingness to engage in the treatment process? And the answer is D. It's their readiness to change. How ready are they? Some people come in and they don't want any treatment. They're just getting the assessment done because their attorney told them it might be a good idea. And then there's those that come in and they're ready to go. They're like, I need help now. How soon can you help me? I'll do whatever you want me to. Those are the ones that you want to get into treatment right away. If you go to the next slide. So there are risk ratings within each of these sections, and these act as a guide for the clinicians, care providers, support staff. A rating of 0 will indicate that there's no concern or the patient is in stable condition for that particular dimension you're looking at. A rating of 4A or B will indicate significant concern and the presence of an acute condition in that dimension. Risk ratings are based on direct observation, current patient information from multiple sources, as well as historical information from the patient's records and self-reports. Next slide. When assigning a risk rating to each dimension, remember, it may not match word for word. Just focus on selecting the risk rating that accurately reflects the patient's condition, most accurately, for each dimension at the time of review, usually during the assessment. Because when we write up our assessment reports, the state also requires us to meet the ASAM criteria. So we have a separate section that we call ASAM criteria right at the top, and we list each section, and then we'll put in there where that patient falls in each area. The risk ratings for mental health disorders and substance use disorders are assigned separately in dimensions 4, 5, and 6, but will often interact, influence each other at the time of assessment and are through the patient's treatment stay. Could go to the next slide. ASAM criteria, 6 dimensions, and risk rating. So we're going to walk through each dimension right now. Looking at treatment patients in diagnosing dimension 1 for acute intoxication and withdrawal. Is the patient, if you see here, he would be the risk rating 0, 1, 2. Patients fully functioning, good ability to tolerate, no signs or symptoms of intoxication or withdrawal, or nothing, they're doing pretty good. 1, the patient demonstrates ability to tolerate and cope with some discomfort. Mild to moderate intoxication or signs and symptoms interfere with daily functioning, but they're not dangerous to themselves or anyone else. There's no very minimal risk of withdrawal. And 2, the patient has some difficulty tolerating and coping. Intoxication might be severe, but they respond to treatment, and they're not in any imminent danger to themselves or others. Go to the next slide. And then here's for a 3R4, we're still on dimension 1. So if we were going to give the patient a 3, the patient demonstrates a poor ability to tolerate and cope with withdrawal discomfort. Severe signs, if we're going to give them a 4, this patient is incapacitated with severe signs and symptoms, severe withdrawal, seizures, continued use and an imminent threat to their own life usually. Next slide. ASAM criteria, biomedical conditions, number 2. Again, here's 0, 1, and 2. 0 means they're not having any problems. 1, the patient has some ability, mild or moderate symptoms that interferes with their functioning. 2, the patient has difficulty tolerating and coping. It might interfere with their treatment. To go to the next slide. 3 and 4. Patient demonstrates poor ability to tolerate and cope, severe medical problems, and 4 would be your most severe. So these ratings are from 0 to 4 of where you're rating them. We can go to the next slide. We're in dimension 3, emotional, behavioral, and cognitive conditions and complications. 0, 1, 2, and 3. 0 is none, or maybe they have a problem, but it's stable right now. Maybe they're getting medication. 1, the patient has a mental disorder that requires intervention, but it's not really severe. It's manageable. 2, risk rating implies a chronic mental illness, can cause some interference with their life. We can go to the next slide. A 3 and a 4. 3 is characterized by severe psychiatric symptomatology, disability, and impulsivity. So they may be lacking control. And 4, patients have a severe psychiatric symptomatology, disability, and they may require involuntary confinement. These are people sometimes that we need to get into the hospital right away. Next slide. Dimension 4. This is the readiness to change. And we're looking at the relapse risk for their substance use and mental health disorder at the same time. So you want to look at the both of those when you're assessing this criteria. 0, patients willingly engaged in treatment. They're committed to changing their whatever problem they're presenting with. Number 1, substance use. The patient is willing to enter into treatment. They want to learn. They want to get some tools, and they have a lot of confidence in themselves that they can do well. Mental health. The patient also willing to get help for their problem, and that their treatment is sufficient. So maybe they're already receiving care. So we would give them a 1. Next slide. Readiness to change. Here's for the substance use disorders. This is still, we're still on a 2. The patient's reluctant. Actually, yeah, they're reluctant to participate somewhat. They're assessed as having a low readiness to change, and not everybody comes willingly. So this is commonly where most people are when they enter into treatment. Mental health disorders. The patient may be reluctant to agree for treatment. A lot of times we may refer them to go see if they need medication, and a lot of the times they don't take the medication, or once they feel fine, they stop taking it. So we go to the next slide. We're still in the dimension 4. Again, we're looking at substance use and mental health disorders at the same time, simultaneously, of how they're doing here. So this is giving them a rating of 3. They may have inconsistent follow through. They realize that they need help, but they're not really willing to follow through in either of these areas. We can go to the next slide. 4, there's 4A and 4B. So 4A, For the substance use disorder, the patient is unable to follow through. They don't know much about addiction. They don't really see how bad they are. So sometimes it's pretty sad when you see people and you know they need it, but they're going to sit there and convince you they don't need it. They're fine. Same with the mental health. Next slide. I apologize. I have several slides here and I'm looking at the time. So if it seems like I'm speeding along, I apologize, but these slides will be made available to you if you want to finish reading the rest of them. B, 4B, same thing. We're pretty severe here. So you want to look at both of the mental health and substance abuse disorders because those two really work together. Next slide. Relapse, continued use, or problem potential. Again, 0, there's no problems. 1, there's minimal problems. And because of time, I'm going to jump ahead here to the next slide. Same, we're looking at substance use and mental health at the same time. Maybe they're doing well, they can take care of themselves just fine. 3, they really don't have much recognition. Next slide. 4, again, it's pretty serious. They have absolutely no control. They need to be put in residential treatment. We need to get them some serious help. Next slide. Let's be same thing. They have no skills. Pretty serious. Next slide. Recovery and living environment. Again, we're using 0 to 4. 0, usually they don't have any problem. They got all the support they need. 1, it's a slight problem. And go to the next slide. And because of time, we're going to jump ahead. Some of these people are homeless. This town that I'm in, we have a lot of homeless people. So a lot of them don't even have a stable environment to maintain sobriety. The next slide is 3. We're getting to where we're getting more severe now. The next slide is the 4, pretty serious. We need to get them out of, sometimes we've got to get them out of dangerous situations. The next slide is a polling question. It's a true false. ASAM's 6 dimensions and 0 to 4 risk rating system are designed as a standalone assessment tool to guide the clinician in determining diagnosis and course of treatment. True or false? Okay, the answer is false. It is not a standalone. We have to rely on a lot of different sources as part of their treatment. Next slide. Levels of care. This is the early intervention. Like I said, might be one-on-one counseling. DUI class. That's where we put our DUI class that we do at our program. Very low level. Next level of care is outpatient treatment, individual and group counseling, family therapy, education groups. Maybe they need a little bit of counseling. Go to the next slide. Outpatient treatment, dimensional admission criteria. So this lets you know what dimensions you're looking at, 1, 2, and 3. This is what qualifies them for level 1. Next slide. Here's dimension 4 and 5. Again, what level of care are we recommending? So this lets you know what they have to meet. And if you get the ASAM book, there is like crosswalk in there that really summarizes all of these really nicely. Next slide. Outpatient dimension 5. So this just lets you know what you're looking at when you want to decide what level of care you're putting them in. And they're not all going to go all straight across. They may be low in one and high in another and moderate in another. So it's just looking at all the different areas. Next slide. Intensive outpatient. Again, this is a little bit more, we call it intensive because we're going to have them do a regular program that they need to be following. And the next slide, dimension 1 and 2. Next slide. Dimension 3 and 4. So this is just listing the qualifiers that puts them in that level of care. Next slide. Okay, the next slide. Yeah, I apologize that I must be talking a little too long here. Residential, again, we're looking at pretty severe issues. And a lot of times we might try them in a lower level of care because they're willing to try it. I'll tell them, we'll try it. If it don't work, it's going to be a clear indicator that you need higher level of care. So sometimes it works, but there's a lot of times that don't. Next slide. Change to the next slide. We're still looking at residential. This is dimensions 5 and 6. Next slide, withdrawal management. Sometimes they need help coming off of whatever they've been dealing with. Can be pretty dangerous for some substances, especially alcohol. Next slide, withdrawal management. Again, there's intake, observation. I used to work in a detox at one time, and we used to see people come in pretty bad shape, but once they can blow zeros, they were allowed to leave. And sadly, some of these people would be back in the next day or two because their use was that serious. And we were also able to get them referred into residential or outpatient treatment if it was needed. Also includes medication and discharge services. And the next slide is another polling question. Oh, let's just look at, if the patient has at least one risk rating of 3, which level of treatment care should be considered? Okay. And the answer is A, intensive outpatient. So that's just at least 1. Okay. ASAM risk ratings on the next slide. This lets you know what level of care you would most likely be recommending. So if all of those risk ratings through each of those dimensions we looked at is only 0 or 1, you're looking at 0.5 or level 1. If the risk rating is 1 or 2, we're looking at level 1. And if the risk rating is 2 to 3, you're looking at intensive outpatient. And any risk rating that is 3 to 4, an A and B, we're looking at residential treatment. So that helps you to define what level of care they need. Last slide, we just covered the assessment process, some assessment instruments, the DSM diagnostic criteria, and ASAM levels of care. And we're on to the last slide. We've got maybe a few minutes left here. If anybody has any questions, comments, thoughts, or ideas before we wrap up.
Yes, please feel free to type in the Q&A box or the chat, please. But I can start us off. Let's see. Oh, we had a question. Are all tribes not for profit in their clinics, and Do they charge insurance if the client has it and they're native?
I don't know about all tribes. I can only speak to where I come from, and we have the Shoshone Recovery Program, and we have the White Buffalo Recovery Program. The Shoshone program is outpatient, and the Arapaho tribe, they actually, within the last couple years, started a very small residential treatment program. And they're, I don't want to say nonprofit. We rely on Indian Health Services funding to pay for their treatment. So most services that are provided are not billed for. One of the treatment agencies charges $25 for the assessment. And, you know, we do try to collect some money. And a lot of these clients don't realize what they're getting for free. You know, I tell them, if you had to go to town, you're going to pay a lot of money for this. And we do bill, I mean, we bill the Indian Health Services. And so if they're an enrolled tribal member, we can get them into the treatment program. And as far as insurance, the only insurance that I know that they do bill is Medicaid. So if anybody has Medicaid, we're encouraged by Indian Health Services to be billing that. So it adds to the income. The DUI court on the reservation, though, to get funding from the state of Wyoming, you have to have the CARF accreditation. And so the program that I work with is a nonprofit. Of course, I'm off the reservation, and we are able to bill the state and on a sliding fee scale. So that's based on income. So somebody who has little to no income could pay $4 to $6 for a treatment session.
Wow. We have another question. Do you recommend any computerized or online assessment tools when assessing clients for substance abuse and mental health?
I'm trying to think if I can think of any that are online. And to be honest with you, I can't think of any right off the top of my head, because for me, it requires face-to-face. And because of this COVID, I'm Zooming people and we're working on the phone. As far as online, I really can't say that there are any. The assessment that we use, the ASI, is built into AccuCare, the Indian Health Services uses. So it's well, not exactly online, but it is an online program that you can enter right into the computer and get the ratings in there. It has everything you need to meet Indian Health Services standards.
Yeah, definitely. Okay. Let's see. How does ROSC apply to MAT, which is pretty much clinic-based?
Medication assisted treatment. It's just looking at the system of care. And I can't remember how long ago, I've been working in this field for several years, but they may still call it that in the school systems, of a wraparound care. And that's just collaborating all those treatment services around that client's needs. So if they're coming in for medication assisted treatment, they're still getting treatment. You still put them in the center and you wrap those services around them.
Awesome. In regards to outpatient assessment and ASAM, how often should a person be reassessed?
It depends on their circumstances. What I like about the ASI and the ASAM is they can be used to determine outcomes of, are they getting better or are they getting worse? So I would say every 6 months, if you could do they call it the ASI Lite, which just hits a couple of like updating questions. And it depends on the circumstances. I might have someone who we evaluated as outpatient program, and they're continually drinking and getting more legal charges. And we're like, hey, red flags are everywhere and we need to get you some help. So we'll reevaluate them. And oftentimes we have to edit their assessment or modify it to get them into residential treatment.
Mm-hmm. So someone asked, are these assessments, I assume, designed to be used by an LCSW, even if not duly licensed? I've had supervisors tell me that listing a substance use disorder as part of my diagnosis is out of my scope as a SWLC and should refer to a LAC instead.
Again, that's regulated by each state. They set their mandates of who can do what. And I do know here in Wyoming, there are some LCSW, but they need to get some training. I've been in places where they give recommendations and they want to make the client happy and give them whatever they want. When really, if you read their information, you're like, this person clearly needs more help than what you're saying. So I think they should be under supervision, under someone who has experience, and they can be trained. I can say that much, that there's no reason that LCSW can't. But again, you have to check with your state, and maybe that just might require some training.
Mm-hmm. Perfect. Okay, and we have one more question. Someone told us, due to COVID restrictions, our tribe shut down, courts and everyone. Now I'm doing assessments with no UAs on people I have no idea if they are actually sober. When before COVID, there was a log, and their assessment is now expired, so they're getting new assessments, and I don't feel comfortable changing diagnoses without anything since March. Do you have any suggestions?
Wow. And so when you said they're not having any testing, is that the agents? Well, if the agency is doing the testing, we do testing at our own agency, but we don't do it as part of our assessment. Like I said, there is one agency on the reservation that I know of. We discussed it, although I haven't implemented it. And it just depends on the agency. But I did some reading online because, yeah, we were shut down for a while. And my program does do drug testing while they're in treatment so that we can make sure they're staying clean and sober. And there are ways you could do if you could do the mouth swabs, and that they could come and pick it up and do the mouth swab and put it back in the mailbox or the box that you have, so that you can check that. And there are some places that will do the testing if you're closed. Our DUI court program has hired an agency just to do UAs on our clients, so they randomly call them in. But yeah, it's a real challenging situation that we're facing right now with that. That would just be something to make note of. From this time to this time, based on the circumstances, we weren't able to get an accurate assessment because if your agency does drug testing and not being able to do that, I would just make note based on this that didn't include any drug testing.
Mm-hmm. Yeah, they mentioned no one on our reservation is doing face-to-face. So.
Wow.
Well,
I wanted to say must be nice, because I was only shut down for about a week and a half, and all these programs were just put the pressure on us. So we've had to rely on technology. I have one guy who's positive for COVID right now. He's not sick. He was never sick. And the doctor that he saw said, this guy is going to test positive for several months. So we gave him homework and we're putting him on Zoom, and because he wants to come to treatment. But yeah, it's just really challenging right now. But these people still need help. So if you're shut down, I would find some way to start providing those services, even if it's over the computer or over the phone.
Definitely. Yeah. Well, thank you so much for presenting today. We are out of time, so I think we're going to close. But thank you for such an incredible presentation today, Dr. Garcia.
Thank you. Thank you, everybody that came to attend today. I hope this helped you.
Yeah, it's good to see you all here today, and hope to see you next time. See you, everyone. Yes, you all be safe. See you.